Alrighty, we're going to go ahead and get started. We're really excited to have Dr. Brianna Brun here from the University of Rochester. She is replacing Dr. Tawil. We all know there's no real replacement for Dr. Tawil, and big shoes to fill, but I know you're going to do a great job. Dr. Brun completed her undergraduate studies at Iowa State University. She then obtained her MD at the University of Iowa Carver College of Medicine, during which time she completed the Iowa Wellstone Center Muscular Dystrophy Medical Student Fellowship. She completed residency in child neurology at Nationwide Children's Hospital and fellowship in neuromuscular medicine at University of Rochester Medical Center, where she is now working with Dr. McKenzie. Is that correct, Brianna? Thank you so much for being with us today.
Yeah, no worries. I will share my screen here and get started. Perfect. You should be able to see this now. So we will get ourselves started. So I did a very quick about me. These are all my business associates when I work in my at-home office. But as we talked about, I'm a pediatric neuromuscular doc. I'm very interested in FSHD just across the lifespan. So I do see patients kind of across the lifespan for that, and trying to take over Dr. Tawil's clinics now that he's retired. And I also do some muscle biopsy review. And then research interests, very interested in FSHD, again, trying to take over the work that Dr. Tawil has been working on and kind of getting involved in that CTRN for FSHD as well. I'm also interested in cognitive outcomes. As we're getting new therapies, we're not always paying attention to other ways to improve our kids' lives and helping them succeed. I'm interested in transition of care into adulthood for our patients. And then some brief things. I'm an Iowan, a Midwesterner that's turned into a quote unquote New Yorker. Anyone that's been to Rochester knows that it's basically the Midwest of New York. But everyone in Iowa believes strongly that I am a New Yorker now. So, and for those of you who don't know, this is where Iowa is. It's the little face of the man that lives in the map. His name is Mr. Mimel, but I think that is only a thing taught in Iowa. So Iowans feel like they can point out where we're from. So we're the little face in the map. So today we're going to talk about MOVE Peds, very briefly an update for you all, because I know many of you have been interested in this pediatric trial. Talk about why clinic appointments matter, and then also transitioning of care for our teenagers. You can interrupt me at any point if you have a question. If you want to put it in the chat, that's fine. I have a harder time seeing those when I'm presenting, but if you want to raise your hand or talk, whatever is fine, or if you want to save them to the end. So for MOVE Peds, I know a lot of families have been anxiously awaiting. We are hoping to get things up and running in the next few months at most of these places, mostly throughout the summertime is what many of us are anticipating. We have 2 sites in the East Coast, 2 in the Midwest, and then 2 on the West Coast. And if anyone's in Australia, there is 1 place over there in Australia. So these are our MOVE Peds sites. And again, hopefully this summer is when we'll get started. To briefly go over kind of what's
we're going to go get
for a brief overview of things involved in the study. So we're going to have visits every 6 months for 24 months. So that's 2 years, 4 visits. Generally, the study activities will do a physical exam, do some strength and function testing. So these are things like walking for 100 meters, stacking cans and timing them, and some other tests that most of the teens or adults with FSHD have done in other trials or even in clinic. So just walking, strength testing. We'll also do the breathing tests, but they only have to do that when they're seated. It does have blood draws. There's about 4 of them throughout the study. You'll have some questionnaires that you'll fill out, and we'll do reachable workspace. That's what this image is here. I don't know if you can see my mouse. We'll do a laser pointer. So in essence, the child will just be sitting and trying to reach and show how much movement they have, either to the side or forward. And then the final one that we'll do is a whole body MRI. And I know a lot of people have been a little bit nervous about this in terms of what kids are going to be able to do in the MRI, but a lot of times kids do surprisingly better than we expect them to do. Some of the MRIs are going to have the ability to listen to music or watch a movie while you're doing it, but not all of them. And again, a lot of times kids do way better than we expect. We've had a younger patient who's done very well in the pilot study, but again, it's going to be kind of judging patient to patient how well you think they'll do, and maybe even just giving it a whirl and seeing how they do. But again, a lot of our kids and teenagers have done pretty well, just historically when we've done imaging on them. I'll pause here to see if anyone has questions about this, and we can always talk about it later too. Great. Again, just interrupt me if you have things that come up. So clinic appointments. We don't have a current treatment, so why does it matter? I know it can be frustrating since we can't cure it, but from my biased opinion of thinking what we do is important, I do think it is. There's a lot of important things we can do. So in neuromuscular, I believe that we kind of function as a subspecialist that's also kind of like a primary care doctor. So we do a lot of different things. We work with you and your family. We help with testing and diagnosis. We can help provide education to you as a family if it's less familiar to you. As you all know, some people, it's just all of your family has FSHD, and it's very common for you. It's very normal for your life. And so it might not need as much education in terms of just the diagnosis, but even things like we'll talk about later, how to help your kid become an independent adult. We also monitor how things are changing over time. And sometimes things are changing differently than we expect. And then we want to look for other causes. So that's one of the other things that we do, is just making sure it makes sense and we're not missing anything. We can screen for all sorts of issues like lung issues, heart issues, issues with the bones or eyes, and even mental health issues that we can help with and make sure you get to the right doctors. And a big thing is also helping you guys advocate for your families, especially sometimes schools can be, need a little bit of extra support in how do we help the child or the person, or even writing letters. And in some instances, even talking to schools and helping them, things like if you're from a bigger town, elevators in the school, having multiple lockers, having book bags that are easier to carry, or even access to just leaving classrooms early. We can help with letters if the school needs extra support. And the other one that we'll talk about a little bit more here is how to help them transition into adulthood, how to go from being your little kid that needs everything to an independent adult. So we'll kind of transition and talk about that now. And again, if things come up, just let me know. So transitions of care. What is it? Why do we care about it? Why does it matter? So when we talk about transitions of care, what we're specifically talking about is this purposeful, planned movement of a child or adolescent from a pediatric family-centered care to adult-oriented healthcare. And if any of you have helped your kid transition into adulthood, or a child transition into adulthood, that is hard. It's painful for everyone in the process. It's really hard. I talked to my own mother about this, and it was very hard for her to let me go out on my own when I was 18 and 19 and just be by myself. So I imagine even harder if you have been working all your life to advocate and help your child, and now they just disappear into adult land. And when we are looking at kids that have special healthcare needs, only 16% of them and 20% without any special healthcare needs have had an appropriate transition of care. So why do I care about this, and why I think other people should care about it? When we don't transition these kids well, or these young adults, I will keep calling them kids, and I apologize, they are young adults. It is the vernacular we use all the time. But for our young adults, it's really frustrating. There's gaps in their care. They sometimes have then poor adherence because they can't get their medicines, and sometimes can even increase the cost of their care. For our parents and caregivers, your child has less independence. You can be really stressed, especially trying to figure out everything when they're 18 and you have less access. And you can even have unplanned transfers. Heaven forbid your kid decides to switch majors and go to a completely different college halfway across the world, and now you're trying to figure this out. And from a medical provider standpoint, it can be really hard if it's just suddenly happening to transition them to a person that will help take good care of them, making sure they have all the information they need. So this is generally why it's important. And I'm going to bring two kind of data points up that were important for me when what made me really worried and care about this. These are not specific to FSHD. It's just where we have data. So if we just transfer someone without doing any of this transition of care, and we look at people that had liver transplants, 29% of them died in 5 years after transferring care to an adult provider. And if they had diabetes, those young adults, 72% of them had a hospitalization related to diabetes. That's a lot. If you transition before transferring, our liver transplants went down to 0% in 5 years, and only 4% of those kids had hospitalizations. So it makes a huge difference for our kids if we help them along the way. As a parent, you're probably thinking, that's great, but how do we help? What do we do, and how can we help do this? Well, everyone's a little bit different, but this is a great resource. This is gottransitions.org. It's a lot of information put together. There's information for youth and young adults, as well as parents and caregivers. They have some checklists and general information. We'll kind of review some of those today, but not in a crazy amount of depth, because each kid is a lot different, each young adult, but this is a good resource. There are some resources specific for Duchenne muscular dystrophy. Some of those have common themes with FSHD, some of the specifics of who's your spine doctor, who's your neuromuscular doctor, but some of the nitty-gritty details aren't quite the same. So this is going to go kind of age-wise. And again, each one of your kids or people that you know might be a little bit different. So this is general, and you can kind of piece things together with the help of your own knowledge and your doctor's knowledge. So at age 12 is usually when we start talking about this, or we should start talking about this. I will admit, this is a newer thing that we've talked about in pediatric medicine and adolescence. So not everyone's fully on board and fully switched to these things. But around 12 and 13, which most of you are going to feel is very young, that's when we're going to start talking to our kids about what their health condition is, what medicines they're on, what allergies they have, and family history. This isn't like a lecture and a quiz. It's the starting to discuss things so they kind of understand what's going on with them and their family and start having a better sense of what their medical problems are. And this is when you start the discussion with your doctor. This is very early stages, so it doesn't have to be in a ton of detail, but just making sure they're being a little bit more involved in their care and the appointments. And then at age 14 and 15, probably when you're starting to get a little bit more of that teenage angst, that's when we start talking to kids about, what do you do in a medical emergency? Do you know where the emergency room is? Do you know when to go to the emergency room? How do you go to the emergency room? Things that make sense as adults to us, but not necessarily as a child. If you can get them a copy of their insurance card, they can just start carrying it just so they have it. And then you can start showing them things like, how did we make a doctor's appointment? How do you order your medicines if they have medicines? And if they're taking those medicines, you can even start transitioning into them taking them more on their own. I usually talk to families about the very first step is just having them ask for the medicine in the morning, and then you're still there to say, hey, you need to take your medicine if they forget. And you can slowly transition that to things like phone alarms, or even if you have a little weekly med box, you can put the meds in. And so then you can just check as the parent as they get more independent and they can feel like they're in charge, but you still get to check and make sure things are going well. And that can just be a really hard thing. I mean, as an adult, we miss medicines sometimes. And so this just helps them get used to that process. And this also is around the time that you'll start having the doctor ask you as a parent to step out of the room. And that gives them a moment to talk to the doctor by themselves. Some kids hate that. Some kids love it. Most kids ask me 0 questions, but it gives them the opportunity to ask a question. sometimes bring up things that they might be embarrassed to talk about in front of their parents. And then it gives us time to check and ask them, things like drugs and alcohol and things that we need to ask them and have them give us answers that aren't filtered through worries of parents, and make sure that we're keeping them as healthy as we can while you guys are doing what you can at home. For this, I will let you all know that all of the stuff that we discuss with the kid when the parents aren't in the room, unless it's a risk to their safety or someone else's safety, or something that we'd otherwise have to report, like abuse concerns, the rest of that we do keep confidential as a patient-provider confidentiality. And that can sometimes be a little bit frustrating, but that's to build that kind of relationship and trust between the doctor and the child. If the kid tells us no, and they do not want to have time alone, that's the answer, right? Because they need to also have their own ability to advocate and say, I'm not comfortable with that, or I am comfortable with that. Then at age 16 and 17, this is really when they should start being more responsible for doctor's appointments. If you have a MyChart or equivalent ability to access your medical record, they should start to get access to their own MyChart, because at 18, parents lose all access to that. And so this makes sure that they are able to use it while you're still also able to use it and show them the way around. Again, still working on that ownership of their daily medicines, and then starting to learn what it means to be 18. So the things like, after you're 18, your parents can't call and talk to the doctor unless you sign a paper. Also, some kids aren't going to be able to make decisions by themselves after they're 18. They'll need some extra help and care. And so around that age, talking with your doctor about if they'll need a guardian or if they'll need someone in charge of their finances or something after they're 18, you can kind of talk with them and work with them on that. And then some people will also create a medical summary. This is nice if you have a lot of medical issues. It can be very cut and dry. This is my diagnosis, this is my meds, my allergies, and my surgeries. And that way, if they ever go somewhere, they have that with them and they don't have to remember it. Some people just keep their MyChart up to date and use that, but it can be helpful to have a little summary in case, again, they go, I'm in Rochester, so if they went to LA and went to college in LA, it gives them something to keep with them. And now when they're officially adults, this is legal adulthood. So this is a hard transition, especially if you turn 18 in high school, when you are still under presumably your parents' roof and their rules, but you suddenly have this rule of the parents can't just call and talk to the doctor at some institutions unless they have consented. Around this age, and it doesn't have to be this age, we like to bring up the inheritance of FSHD and start just seeing if the person is interested in having children in the future, so that they understand what the risks are and then they can make informed decisions. I know many people would prefer they wait till they're like 35 or 40 before they start thinking of that, but it's a good time to just review that and make sure they feel like they understand. And then start working to figure out the adult provider. In neuromuscular, again, we sometimes just keep our patients in neuromuscular forever because we get trained in adult neuromuscular as well. But heart doctors and lung doctors usually around 21 is when they'll transfer their kids to adults. So making sure they can find a new doctor, and your doctors can help with that those doctors then get access to medical information, and then making sure that the place takes your insurance and if there'll be extra charges, because you don't want to get a big surprise. So just doing those things to make sure that they can see the doctor there. And then finally, once they're kind of in that by themselves 22 to 25 age, where we wish we could have more control, they should continue to see their adult doctors, really be managing their health care. And then the important thing is to make a plan if they are still on a parent's insurance as opposed to Medicaid or Medicare, I guess it'd be Medicaid, that they have a plan to transition to insurance. Most insurances, after the age of 25, you can no longer be a dependent on your family's insurance. And I think that is a surprise to most 25-year-olds that are on their parents' insurance. So this can help just keeping that in mind. So this is pretty nitty-gritty. That's what I had put together for you for like transitions. And I figured if you guys had questions about that, we could go through that or any other questions as well.
I have a couple of questions. You know, a lot of times with FSHD, kids aren't diagnosed until they're in their teens, like a lot of times 14, 15 years old. And obviously that compresses that timeline a little bit.
Right.
So if they're diagnosed around 14, 15, how then do you take them through it? You just sort of, you know, speed up that timeline. You know, my son is 19 and he even has a hard time now making his own doctor's appointments or dealing with insurance because it's complicated. And
Mhm.
like what he wants to do is hang up the phone. Like they give him an answer and he's just like, okay, bye. And I'm like, no, no, no. Follow up, follow up, follow up, because you rarely get something done the first time you call, right? With
Right. Yeah.
insurance. So how do you compress that timeline when they're, I guess I have two questions, when they're diagnosed later, and then also there's a lot of folks in the community, and this kind of ties back to the care and also the MOVE Peds, that they kind of know that they have FSHD because it's in the family and they kind of see the symptoms, but they don't want to tell their kid that they might have it or it's in the family, so they're never officially diagnosed. So if they're never officially diagnosed, I think that that graphic you showed about when they go into adulthood, like, you know, the problems that they have, like
Mhm.
that you showed, I think that's really
This,
important. Yeah, but the liver folks, because if they've never learned to care for themselves or they don't really understand FSHD and now they're an adult and they're thrown into it because you never told them or they never had any care, they've never been tested. Now they're falling into this category of a greater risk because they don't know how to care for themselves. I know I've said a lot. I mean, I just wonder if you can talk through that a little bit about being
yeah.
diagnosed as a teen or never having been told that you
Mhm.
have it. Or maybe the parents didn't know. Maybe they got diagnosed. That happens a lot in families too. Like their parent won't even know until they're like in their 50s and their kid might already be 18 or something.
Yeah. And so that is difficult. So it does speed up your timeline if you get diagnosed later. So let's say you get diagnosed at 16. Some of these things you can start even if you don't, if your child just happens to be 12 and doesn't have any medical problems, still talking to them about, hey, you've had your tonsils out, or you're allergic to penicillin. Things like that, you can always start. But if you haven't, because I would say most people don't, because most healthy kids, they do what they do. Um, but if it starts later, if you get diagnosed later, at that point, I think it's still important to encourage them to be part of the medical visits. So talking with the doctor, it's really easy for all of us, even if I take my husband just to his primary care doctor, to not interrupt because we're so used to, I'm coming from a different place of it's easier for me to just tell the doctor the things that he's told me already in doctor talk, but that's not fair for him, right? So letting them add their voice, and sometimes you can sit behind them and not talk, but still let us know your opinion. So sometimes kids will be like, I have no pain ever, never had it in my whole life. And the parent will just be like, because they've heard it before, right? And so then you can, add your voice and say, sometimes you complain about this. Is that something you want the doctor to know about? And encouraging them, like, this is where you tell the doctor things that you might not know if it matters or not, but that's their job, is to help you figure that out. And so encouraging them in those times. And yeah, you in essence just kind of speed it up a little bit. So you might not have been practicing making doctor's appointments because they might almost never see the doctor. So then if they're 16 or 17, showing them how you do that and having them involved in that process. and then starting it a little bit later. And some of these things, again, if your child needs more help, you might still have to be doing it when they're later, like older, because this is, presuming that they do well and they're like able to do some of these things on their own, because not everyone is able to. So that's part of it, is you just kind of speed it up a little bit and try to prioritize the things that are going to be the biggest thing for them. So if they won't need help making healthcare decisions after 18, you don't have to review that as much. If they are probably going to go to college in town, you don't have to review how do you find a brand new doctor right away. I think that's part of it. Your other point of kind of waiting for diagnosis or not being diagnosed, or even feeling like we kind of know the diagnosis. I do live in the space that I think it's helpful still to get a formal diagnosis. And that's because then sometimes that can open the door to more services. So physical therapy, a little bit easier to see certain doctors, and even get doctors that then know more about your disease and you think about it a little bit differently. But also, a lot of times we don't give kids and young adults enough credit for the things that they do know. And it feels like it's protecting, but sometimes they're sensing that you're nervous about something, or even Googling. That's, especially nowadays, a lot of kids will Google things and read about things like, why is my face weak? Why are my scapulas weak? And figure out things and figure it out in a way that is less helpful. So we've had patients who have read on the internet and find out that you might need to be in a wheelchair one day, or you might have difficulty breathing, or you might need X, Y, and Z. And it's told to them in a much less caring way than if a parent can talk to them, or even medical providers. We can help with some of that discussion at an age appropriate level. And that should be a thing that we're helping you guys do. And if the provider doesn't feel comfortable, there's usually other resources available to help bring it to them at a kid's level of, what does this mean? How do we help? And in some places, even like siblings that aren't affected, you can have a similar conversation. Does that kind of explain it?
Yeah, so for the move peds, you have to be genetically diagnosed to be eligible, or you have to, from what I understand, you have to be genetically diagnosed, or you have to have like you have to be clinically diagnosed with like a parent or something that has it. Is that correct?
Yeah.
Okay, so you
Yeah.
either have to be genetically diagnosed or clinically diagnosed with a direct line,
Mm-hmm.
right? To get
Yeah.
into any studies, and if you want to be eligible for any interventional trial, for sure you have to be genetically diagnosed, and that can take some time. So
Mm-hmm.
if your child, let's say they one day, hopefully, God willing, they have a pediatric interventional trial. If your child isn't genetically diagnosed, then it may take a year or 2 years for them to get that diagnosis, and they may miss out on getting in a trial or having access to the treatment once it's available, because they don't have the genetic diagnosis, correct?
Yeah. So having the genetic diagnosis will open more doors towards research, or having a clinical diagnosis, even for very specific like drug trials, medicine trials. You usually have to have a genetic diagnosis. Um,
But let's
and
say
then
there's a treatment and then you want to prescribe that to them. They have to have a genetic diagnosis to get that as well, correct?
typically insurance will, at least in American and United States insurance, you'll need a formal diagnosis to get access if it specifically says this is approved for FSHD. Yeah. And then with the kids, obviously many of you know that we're doing more studies in adults right now, and the goal is to do those in children as well. But again, you'd have to have a diagnosis.
And the age for move peds is 5 to 17, is that correct?
Mhm.
Okay.
Yeah.
I had one question. Does anybody else have any other questions before I ask anything? Anybody else?
I have one question. So our son, he's had the genetic testing and all that, and we working with Kennedy Krieger Institute down in Baltimore. We live in New Jersey.
Mhm.
And he's 17, he'll be 18 this summer, so getting closer to an age where he can maybe be in some trials or whatever. And I was just curious, so for example, if like Rochester is running one, but we're not a patient there, my understanding is then you maybe can't get into that clinical trial. Is it suggested that we have him have like an initial appointments with multiple hospitals? Like I feels confusing, that piece of it for us.
Yeah. Do you guys have your doctors talked with you about clinicaltrials.gov at any point? It's not an easy site to look at. I will
Yeah,
say.
I've been on that site.
Okay.
But so he was only just diagnosed last summer, and
Okay.
no one else in our, and my husband and I were also tested. We don't have it at our, so it's like we have no background on any of it, so we're pretty new to everything. And
Yeah.
everyone's been wonderful, and we join all of these calls, so thank you so much for hosting them. But yeah, just trying to understand, because we talked to some other people, and they're like, oh, you need to go to like multiple doctors or centers so that you're on multiple people's lists. But that also seems like overwhelming also. Like I don't want to run him to
Yeah.
all different states all the time just to get on people's lists. But is that what you need to do typically?
Not typically.
Oh, okay.
So if you're interested and your son's interested in trials and he's at the age that,
He's getting closer.
yeah, and even if it was like I think there might be one going down to age 16 right now, which is
Yep.
better. It's
Yeah.
still not, everybody else. But you can talk with the doctors where you guys are and say, are there research trials? Are you that he could be eligible for anywhere? And
Yeah.
is there a way that you can connect us to them? Because usually
Okay.
there's like a clinical trial coordinator or a recruiter of some sort that would
Yeah.
be able to organize that, even if you're not a patient there.
Great. Thank you.
They do, this is Dave Rubin, they do all know each other. A lot of these, the people doing this cruise is a pretty small world. So it's important it may not be important to have to book neurology visits at every one of these locations, but it's important to contact the people at each of the locations to let them know that you're interested in, and they may ask you for the genetic testing. They may ask you for a medical record to send that over to them. So at least get your name in with all the people is my suggestion.
Thank you.
You're welcome.
I'm sorry, can I just clarify, how old did you say your son is?
Currently he'll be 18 in July.
Okay, I guess I would just encourage you to go to clinicaltrials.gov right now, because there might be a trial that he can participate in at the current moment.
Okay.
If you would check that, yes.
Thanks. I'll do that. That was all for my question. Thank you.
Oh, yeah, perfect.
I had a quick question about so my oldest, I have 3 kids with FSH, but our second is getting ready to go to college, and he has it much more severe than any of our others. And so we've had to, we've done all the accessibility things, though he's still mobile by himself, but he just is having a lot of decline. So my question, I guess, is as he has been in a place of I don't have anything wrong with me. The big denial world. He's
Yeah.
finally having some ownership. He has about 5 hours of therapy a week. He's really working hard to stay as active as possible. But I guess what I'm saying, as we do this, like transition to him living about 4 hours away, him going to new PT on his own, we're going to keep our same doctors and everything, but all of this big change, I guess can you think of, or any other, can you think of a practical way that I can help him with ownership as that transition, and then how's I guess a good way that he can communicate with us as he has loss, as he's in this world of denial. It's kind of hard I'm usually the one talking to his therapist who's telling me, these are the losses we're having this week. I mean, it's kind of that fast right now. So I guess I have a lot of fear for what's going to happen when I guess that's every mom, like as when our daughter left, there's fear when your kids leave to go to college, but this is just a different kind of letting go. And so I guess I want to thank you, one, for speaking to that, and like not and just speaking to it so gently, but also just, do you have any advice as he's having losses, how to keep that line of communication open?
Does he, would he be open to like any support groups for his age, or is he kind of in the denial for that too?
He is thinking about that.
Okay.
So I'd
Sometimes,
say, yeah, he's having some more ownership, but
okay.
it's definitely slow. And I guess that's, that would be really hard. So
Yeah. And when does he move?
he'll move in August.
August. Okay. So you have a few probably therapy sessions before that, I imagine. So you could have him be involved before. So do you make a written list that you take, or is it just kind of you have a list in your head because that's how
Our
you?
OT and PT both are pretty close friends of mine. Like they'll call me with things that he's struggling with. I mean, he's already signed a waiver. They can talk to me, so that's
Okay.
nice. But yeah,
Yeah.
he'll go to all new PT and
Okay.
everything.
So I think what can be helpful is to maybe write down before his next therapy, like what things you bring to them in therapy sessions or talk to them about, so he can see what you're doing, because you're doing a lot of mental load, right? And helping him in that way. I mean, it's what parents do, but you're writing things down or keeping them in your brain and trying to organize them. So showing him what you're doing and be like, hey, like these are the things that they want to know about. A lot of times, teenagers and young adults, especially when they're in that denial phase, almost feel like it's a burden to bring it up to doctors, even though it's bothering them. And that's a common conversation that I have in that like 19 to 21-year-old age, is like, no, that's the thing I want to know about. It's okay to tell me that. And I think especially in that age, to let him know, like, even if he overshares, it's fine, because it's our job to figure out what's important and not less important. But maybe just showing him what you're doing, like, these are the things that I would bring up. How do you feel about them? Are these things that you would bring up too? And maybe showing him what you're doing as he goes. And then you can also talk with him about his comfort level as he's going to new providers, with you also being able to discuss with them. But it is a scary time.
I have one more question. So again, our son is, newer to this, as are we, and I hadn't heard it before, but he's definitely in a denial stage. I really guess I didn't think of it that way.
Mhm.
Is that fairly common for that age? Like he doesn't really even talk, my husband's sitting next to me, he doesn't really talk to us about it, but he'll text me once in a while with something. Maybe that's just easier for him to talk about it that way. But like he hasn't told any of his friends what's going on, and they know something's going on because he doesn't have a lot of use in his right hand. But they just think like, oh, he had an injury or who knows what, because it took us like a year to get a diagnosis. So for a long time, they thought it was just like nerve damage. And I think he probably told people that, and they just think it's still that. Is that fairly common though, that you see that, like for that age, like, they don't want to maybe admit something's wrong, or, and is there a way
Yeah.
to coach them through that?
Common in adults. It's common in adults as well.
Yeah, okay.
Yes. Pretty
Well, it's a
common at
hard thing to
anyone.
explain what it is, right? Like you say the
Yeah.
name and people are like, what? Like, yeah.
Yeah. So it's, I think, common in anyone that gets a new diagnosis, no matter what it is. Anyone who's ever had the flu, even though they know it's the flu, it's still a period that you're like, it can't be. And then add something that's lifelong, it can be even more significant. And then teenagers, especially if they function the same as their friends for quite a long time, it can be difficult to see something that's different in that age, because they're so reliant on their friend group. That's normal development, to be away from their parents and caring what their friends are saying, which drives everyone crazy, but that's normal development for a teenager. And then to notice that things are different, they can kind of ignore it or make it seem like nothing's wrong. And so a lot of times I try to reframe it, I guess, as saying, like, the reason it's important to think about this is so we can advocate for ourselves. So sometimes you look like you can walk up and down stairs with how you move around, and you just can't. And so being able to just say, hey, I'm not able to do that and I need to do something different. So sometimes if you frame it that way, it doesn't feel as much like they're admitting there's a problem, quote unquote. There's something different about them. It's just, this is the way that I support myself best, to say I need to use an elevator or say I need to take a break. So sometimes I frame it that way and it's a little bit easier to swallow for the teenagers.
Within, I lead one of the chapters, and within the chapter I led, I had two parents with young adults who both said that they found that their kids got actively involved with, were in denial, but got actively involved with Better Life because it's close to social media-ish for them, I guess. And that they began to open up because they were on that. One guy said his daughter wouldn't even talk about it, but she was on it. That's John Kim. You're welcome to talk to him. He's open about it. And he said, she's young adult, and he said she's become more open as she started to look at more and get involved with Better Life, which she was doing on her own privately.
That's a great idea. I had signed up for it, but I don't think he has yet. So I'll go back and encourage him. Thanks, Dave.
Welcome.
I actually had a question about Rochester. I wanted to introduce myself. My name's Vera Triance. I have two daughters, 7 and 8. They're very severely affected. My 8-year-old needs a wheelchair now. We're patients of Dr. McKenzie. Yeah, we're actually coming up there next week for the MOVE study. We've been in the original MOVE study for this is our 3rd visit. So yeah, I was just wondering if you could share how like the structuring of Rochester is now, like how many people actually replace Dr. Tawil. Yeah, because I thought we were making the best decision going with Dr. McKenzie, or
Yeah.
Yeah. Okay.
Yeah, he is also
Yeah,
helping a lot with FSHD. He is been here a couple of years now, I think 3 years maybe. So he's also helping with FSHD, so he's great. I think most people would agree. He's also trying to be involved a little bit, but his research has been kind of taking him a slightly different direction, but he's still a great provider. And then, so he and I primarily see the kids that have FSHD. And then for the adult providers, it's alarming how many people we need to replace Dr. Tawil, but also not surprising. So primarily I'll see the adults with.
Yeah, we were actually his last patients when we were there in July. Yeah, we were the last ones
and then
to see
Dr. Hamill as well. And there's a couple other providers that will see FSHD in clinic. But we're trying to start a specific clinic for patients with FSHD. We just started working on the details.
So what do you mean when you say Dr. McKenzie's research is taking him?
Oh, he does some other research in like myotonic dystrophy as well, but he's kind of has his fingers in a lot of pots.
Okay.
For research, yeah. But he's very well informed and he's a good doctor too.
Okay. Yeah, we're happy with him. Yeah. Well, I'm happy to meet you. So yeah, we're gonna see him on Wednesday. So I don't know if we see a doctor at MOVE or if it's just the PTs. Yeah.
It might be for that one. It might be Dr. Lee. Or
so will any of that data carry over? Oh, am I going to meet you on Tuesday? Yeah. Okay, great. All right. So I'll just save my questions for when I see you in person.
Okay.
Any other questions? I know you've given us a lot of information, a lot of valuable information here. I wanted to ask you something. So at the MDA conference recently in Dallas, Sanofi did a poster brief. They did a meta-analysis of FSHD. Are you familiar with the poster that they briefed?
I don't think I saw that specific one, but go ahead.
So they did on the life expectancy for FSHD, and basically they took a lot of different publications for early onset and for traditional onset FSHD. And so for early onset for the kids, it's about 20%, and that's what we've been saying, our group, that the mortality rate is about 20% for early onset FSHD. And the average age of death from that meta-analysis was 16.6 years or something like that. And then for the traditional onset, it was 64 years, which is significantly lower than the typical, you know, lifespan in like the US and UK and Australia. So given that information, and now that more people are talking about that, is how then can the clinicians use that information to better advocate for their patients, especially the young ones, to be included in things, in clinical trials and expanded access and things like that. And how best can we get that information? Because it's always been there. It just hasn't been compiled. Like, these aren't brand new studies, but they compiled it and they briefed it. And from my knowledge, it's the first time that it's really been put out there like that. And I appreciate it because, you know, I think it's valuable information. So how can you guys best use that? And how can we best use that to advocate for our causes?
Yeah. And because I didn't see this poster and I apologize, was it after diagnosis or just total life? Do you remember?
It was just, I mean, it was just like, okay, they took like, okay, you're diagnosed, say, at 7 years old. And so all the studies that they had ran, like in the Netherlands and some in the US, and then they just took those pubs and they did a meta-analysis of it and said, over the lifespan of these, like the Netherlands had a very long study that they ran over, like, it was like 22 years or something for early onset, and like one or two of the people died. And then they had another study in early onset, and a couple of them died during the study. So basically they just took these studies and then they did a meta-analysis, and they said, based on this, FSHD does affect life.
Yeah, it's a terminal disease.
Yes,
Like
right.
Epic Bio, you know, they're now using the wordage that, you know, it's terminal. And I agree with that. If something doesn't come a treatment for my daughters, you know, they're not going to have a, you know, you're talking about transitioning to college. We're not going to see that if something doesn't change.
Right. And so now this information, I mean, it's like I said, these studies were done from, you know, 2015, 16, 21. They just took all the studies and they did a meta-analysis and they did a poster brief on it at MDA. And like Vera said, and now Epic Bio saying for early onset, you know, if you don't get a treatment, it's not going to be a good outcome. You know, respiratory issues are a real thing. Some people have heart issues, and
it's a terminal disease. I really would love to see that written more frequently.
Right. So so as a clinician and the clinician, the family of FSHD clinicians, what do we need to do to get that word out more? And how then can you use this information to advocate for treatments for the younger folks and for everybody really? But, you know, I think, you know, 64 and 16, that's a big difference.
Yeah. And I think that the big thing is that I think all of us have to be a little bit pushier. I think that advocacy is important. And so from providers' aspects, I think that we have to be, a lot of times when we're trying to make research and make grants, you're trying to sell it to someone who has money, in essence, that will give you support for that research. And I think papers like that and studies like that help support us in saying why it is so important that we involve patients that aren't 18 and older. There's a lot of worry in research that you're taking advantage of kids sometimes, even with parental consent, and then patient assent, so agreeing that they're willing to have it done to their body. But we do it all the time in other diseases that are terminal and have significant impacts. And I think that we have to, in medicine, probably need to be a little bit pushier about that and having that as something to cite and say, here's where we got this data. It's not just our feelings. It's not just what we see clinically, it's data. And so from our perspective, having data like that is really helpful to show it to someone and say, we're not making this up. This is a big deal. And then we can add all the voices that you guys have, which is, this is terminal. This is infecting my family, my child, and they don't have access. And so I think by showing people that and having, I mean, you guys have groups like this where you're spreading awareness. I think that's what we can do from our side, and your guys' side is keep being pushy.
Right, and that's a good word to use, pushy, because really it comes down to the sponsors, you know, and like you said, there has been a lot of concern in the past to, you know, protect children, but the FDA is changing on that. They're you know, their philosophy is, you know, they used to be protect kids from clinical trials, and now it's protect kids with clinical trials, because you're not protecting them by keeping them out of clinical trials and then they're dying. Like,
Right,
that's not
exactly.
helping anybody, right? But but it's slowly changing, and with FSHD, because the literature has been so benign for so long that this is a slow progressing disease, it doesn't really have any impact on life expectancy. It's taken a little bit of time to change, you know, that narrative. And we just need to make sure that the clinicians are on our side, and that the, you know, all the patients and the parents, and we're all singing the same tune, so to speak, to the sponsors to be pushy, as you would say, to say, look, we need this, we need these treatments to come to our younger folks sooner rather than later.
Yeah. And I think by continually showing that the kids are very severely affected, I think that's what is helpful to remind people, because a lot of times in medicine, people just think, oh, FSHD, it's an adult onset, slowly progressive disease. And even, you know, with my own child neurology colleagues, reminding them that it can show up in childhood still surprises some people, right? So still in medicine, we have to advocate for that education and the research support. And then you guys as well. I mean, by existing, you're kind of advocating for your children.
Right, because it's very frustrating as a parent to see your child in such a steep decline and struggling so much, and you just keep hearing that over and over, that it's not that impactful, like it's slow progressing, it doesn't impact their life dramatically, and it's just not true in a lot of cases. Some cases it is, but in a lot of cases it's just not.
Right. Yeah. Okay. So I think that's all of our role is to just advocation, I guess, is the other word, advocating, but I think pushy is kind of where we need to be.
Currently. I like that pushy. Anybody else have any final questions before we wrap up? No? Well, thank you so much. This was really valuable information. I appreciate it so much. I think everybody got a lot out of it today, and this will be recorded and it'll be posted, and I'm sure a lot more families will benefit from all this information that you've given. So thank you so much. And say hi to Dr. Tawil for us, and Dr. Lindsay.
He still comes every Friday, even though he doesn't work there anymore.
And thank you so much for everything you're doing for the community.
Yes, thank you guys for letting me come. And
thank you guys. Have a good evening.
See you Tuesday.
Happy Easter,
Bye.
everybody.
yes,
Bye.
bye everyone.